Okay, I think that we will get started. So thank you all for dialing in for today's congressional briefing on reducing cancer exposure for patients and doctors. The next slide goes over what we will cover today. We're going to start out with some introductions so you understand who our speakers are today. They're pretty impressive physicians and experts in health innovation. We are going to share a brief video that really is compelling and explains why this exposure to radiation is completely unnecessary and is actually taking people's lives. We'll talk about medical advancements that can address these problems when it comes to unnecessary radiation exposure in medical procedures. We'll hear from renowned physician across the country, a leading expert, to share his expertise as well as others. And we're going to close out with what we think the government can do to make a difference, to remove this unnecessary risk to radiation exposure. So next slide. So this gives you a snapshot of who all the speakers are. So I'm Liz Powell. I'm a former legislative director on Capitol Hill and the founder of G2G Consulting, and we do a lot of work with health innovation. We have Dr. Madhu Mohan, who is a physician trained by NIH with Maryland Radioactive Materials License. He's the executive medical director, Doctors Community Hospital, and also director of Riverside Clinical Research Center. So he's a great expert. He will share some insights as to why this is a concern and the changing dynamics in population health that's impacting why we have so many more of these procedures that are exposing patients to radiation, as well as doctors. We also have Dr. Matt Eagleton, who is the chief of the Division of Vascular and Endovascular Surgery, co-director of Fireman Vascular Center, Robert Linton Professor of Surgery at Harvard Medical School and at Massachusetts General Hospital, one of the nation's leaders when it comes to healthcare. And then we have Vikash Goel, who is an inventor, entrepreneur, and consultant, worked with Cleveland Clinic for many years and is the CTO of Centerline Biomedical. So those are our impressive speakers today. So with that, I will pass it over to Dr. Matthew Eagleton.
So radiation exposure due to the use of fluoroscopy is a well-known entity, but its awareness as causing a negative effect on our long-term lives has just recently become aware to the population of physicians. It's a topic of many meetings across the world now, and most recently at the largest international conference for vascular disease termed Charing Cross, they had an entire session devoted to how physicians can prevent themselves from undergoing lifetime exposures that become detrimental from their health perspective. During this meeting, they highlighted several key leaders in vascular surgery and in vascular interventions who have been negatively affected by their lifetime exposure to ionizing radiation from the use of fluoroscopy. Some of the ones they highlighted are Ted Dietrich or Edward Dietrich, Dr. Krasi Avancia, Dr. Roy Greenberg, and Dr. Alan Reed. And these are just leaders in vascular surgery who had significant health problems because of their exposure to radiation and the use of fluoroscopy to perform their procedures. This is just a fraction of the people that have been affected by this, but they wanted to call out names of people that our population of surgeons would recognize. Prior to his death, Ted Dietrich died of a brain tumor thought to be associated with his exposure to ongoing radiation from the use of fluoroscopy. He created a video that helped to represent what the problem is and what we need to be doing about it and how this needs to have more of a public health awareness about it. So if we can start the video, because I think he summarizes it better than any of us will be able to on the next several slides.
All right, let's have you. I drove into the garage and I put my hand up on my button and the garage door came down. And then I reached over with my hand to open the door and I couldn't find the door handle. I lost complete control of my hand. By the time I arrived at the emergency clinic at Barrows, I was in a full-blown seizure. So then they put me in the MRI, and the next thing I remember, I wake up. The surgeon comes in, a young guy. He says, well, you've got a brain tumor. We have to take it out, and then we decide how we treat it.
What we see here are your post-op study. We see a small cavity there with a tiny nodule of enhancement along the anterior lateral margin, which is hopefully post-operative change.
And they said, we removed the brain tumor. We think we got it all out. I said, well, what's next? And then they talked about the next therapy. At that moment, it struck me that I will never be that cardiovascular surgeon again that I was.
Dr. Dietrich was one of the best trained and most skilled surgeons in the country, and probably in the world. There was an elegance in his surgical technique that made everyone sit up and take notice. He founded the Arizona Heart Institute here in Phoenix.
My principal motive was make it safer and make it simpler. And that is the real thing that led into the endovascular field, where you didn't have to make an incision, you didn't have blood loss, patients could be discharged sometimes the same day. But to do that, we had to have the same capability to image and take pictures in the operating room that they had in the catheterization laboratory. I found it in the University of Münster in Germany. We brought that to St. Joe Hospital. And that was the first one in the world, except for the one at Münster.
Working around radiation is sort of like keeping a pet tiger in your living room. It can be great as long as you don't take your eye off of him for any minute.
When we started doing these procedures, nobody questioned what we did. The last thing I was thinking about was how much radiation am I exposing my body to? Yes, I put on the lead aprons, but you can imagine if you've got a lead apron on your shoulder for hours at a time, that creates a lot of muscle spasm, tension, and so forth. Being a doctor, my whole motive was to help the patient and get the patient well. I didn't think about the hazardous conditions. I have no question in my mind that my carotid artery, which had a very, very dense calcific plaque, was related to excessive radiation. I've already had bilateral lens implants in both eyes, and there's unequivocal evidence that radiation is a major cause of cataracts. I'm highly suspicious that that little 8-millimeter brain tumor, the oligodendroglioma, it's the same radiation exposure. It's coming the same way. If it would cause this, why wouldn't it cause this? So I'm kind of a living example of excessive radiation and what it can do to tissue. I think I felt this radiation cannot hurt me. It can't hurt me. I felt indestructible. Obviously, I didn't know what I was talking about, did I?
Good morning. I am Madhu Mohan. I'm a medical panelist today, presenting a few simple slides to give the audience some taste of what radiation is and radiation exposure is. As we all know, radiation therapy, also called radiotherapy, is a cancer treatment that uses high dose of radiation, which is not the subject for today. What we need to understand before I go into the connecting the dots, the general types of radiation. The one which everyone knows is the exposure you get from getting diagnostic X-rays, CT scans, other kinds of X-rays like mammography, etc. There is also a naturally occurring radiation, as you all know, from cosmic rays. And the third category, which is of the topic, is occupational exposure to medical professionals, aircrew members, and also nuclear scientists. There is a 6-fold increase in radiation exposure experienced by healthcare workers in the last 30 years. And there's also 74% increase per capita in radiation exposures in the US overall during this 30-year period. Nearly half of the exposures were related to medical imaging. This slide shows why the curve steeply going straight up. The disease rates from 1990 to 2019 the disease rates for the 2090 to 2019 are doubled up. So is the peripheral artery disease rates also increased 2 to 3-fold. The steady increase in aortic aneurysms also is noted. The risk factors, 22.9% increase in US adults with hypertension and obesity rates, which are doubled up or tripled up in US population. And also we have increasing number of diabetics, which is becoming the leading public health problem in the United States. And of course, smoking, which is of course on decline, but it also contributes to vascular diseases. Next slide. So the prevalence of all these diseases is the cause of the rise in vascular diseases. So vascular disease is any condition impacting the network of blood vessels and is rapidly increasing, fueled by aging population and increase in obesity and diabetes. This obviously results in increasing diagnostic interventions to find out where the vascular damage is and repairs. That is called endovascular surgery. So I think I've connected with a few slides, the various types of radiation here and the reason for the increase of vascular problems due to aging population and multiple diseases in the community and population, resulting in increasing procedures are done with a resultant exposure to our physicians like Dr. Matt Eagleton, who will be our next speaker.
Hi, I'm Matt Eagleton. I'm a vascular surgeon. I'm one of a number of specialties that provide care to patients with vascular disease and cardiovascular disease. Can we go to the next slide, please? I currently work at the Massachusetts General Hospital. I'm a relative newcomer here. I joined the Mass General about 3 years ago, moving from the Cleveland Clinic in Ohio. And I joined it because of its long history of providing vascular care to patients in their community. It's one of the first clinics for evaluation and treatment of vascular disease, and it was established way back in the 1930s. And they've been spearheading the advancement of vascular surgery and vascular techniques since that time. An area of interest in mine is aortic stent grafting, where we treat aortic aneurysms with stent grafts, or in a minimally invasive way, which has revolutionized vascular surgery and care for patients with a complex problem. And one of the reasons I joined here is because they were one of the first stent graft probes for aortic aneurysms in New England, and they've had one of the most extensive cumulative stent graft experiences in this region and in the country. So it was a real opportunity for me to come here. Can we go to the next slide? What is endovascular surgery? Well, endovascular surgery is the minimally invasive vascular surgery where we can treat vascular disease and cardiovascular disease with stents, balloons, wires, and catheters. This is done in a minimally invasive way, which lowers the morbidity or the risks of the surgery and can improve the recovery of patients afterwards because we don't have to make such large, generous incisions in order to treat the problem. It can be done through small punctures. In order to do this, it requires fluoroscopy or special x-rays that allow us to see what we're doing. And while I have an interest, as you can see on the right here, of treating aortic aneurysms, that's just a small percentage of the procedures that are performed. It just happens to be where I have a specialty and where I have an interest. But on an annual basis, there are thousands of providers that are performing millions of these procedures that are dependent upon fluoroscopy. And the procedures are becoming more complex as we try to treat more and more complex disease processes in a less invasive way. And as they become more complicated, they require increased fluoroscopy, and they also require they need an improvement in the type of visualization that we can see with the anatomy. And I'll show you some pictures in a minute to understand why we have to improve the pictures and why that's leading to increased radiation exposure. But we have to keep a standard of care as we increase radiation exposure in ourselves and in the people that work in the operating rooms, in the procedure rooms, and among the patients, is that we have to protect ourselves, we have to protect our patients, and we have to protect the other medical personnel that help to support these procedures. New slide, please. This is an example on the left is just a grayscale two-dimensional image of what it looks like for us when we're using fluoroscopy to do procedures. It's the same solution we've been using for nearly 30 years, and it's, well, some sophistication there. It's not keeping up with the procedures that we're performing. In addition, just to get a picture like this exposes us to great deals of radiation that increase our risk for health-related problems, as you'll hear about in a second. Can you go on to the next slide? The occupational health risk associated with radiation exposure is not minor. We get exposed to a tremendous amount of radiation when we do these complex aortic aneurysm repairs. That's equivalent to hundreds, if not thousands, of chest x-rays performed on a single person. So that's a huge amount of exposure to us. That exposure is not benign. It can cause premature cataract formation. It can contribute to the development of cancer. It can contribute to the development of blood vessel narrowing, as you heard Dr. Ted Dietrich talk about in his video. He suffered from both arterial narrowing on the side that was exposed to radiation, as well as a brain tumor on the side that was exposed to radiation, as have many other physicians that are exposed to radiation as part of their jobs. New paragraph, next slide, please. We do help to protect ourselves, and we wear lead. We call it lead. It's not really lead, but it's a radioprotective suit that we wear, as you can see here pictured on the right. And this doesn't even go as far as what some of us wear. We also wear leaded hats, we wear leaded sleeves, and we wear leaded leggings to really try to protect our whole body. We try to follow a practice of what's called as low as reasonably achievable, and I'll get into that a little bit more, but it's really these lead garments and the use of plexiglass shields to help protect us from the radiation exposure. But these lead garments are not benign. As you heard Dr. Dietrich talk about, after wearing these for hours a day, days on end, it can lead to some significant orthopedic injuries, spine injuries, hip injuries, knee injuries, and up to a third of providers that use this on a regular basis report having missed work secondary to problems related to overuse of their body from simply wearing the lead. Next slide, please. You can see that this is not unknown. Even the FDA has reported that fluoroscopy can result in relatively high radiation doses, especially for complex interventional procedures, and procedures are becoming increasingly complex as we try to treat harder and harder problems in a less invasive way, which is beneficial to our patients. According to the CDC, the guiding principle of radiation safety is ALARA, which means as low as reasonably achievable. What can we do to keep our exposure and the exposure to our patients and the other healthcare staff as low as possible, while providing the best clinical care possible? We do that by trying to minimize the time near the radiation source. So we just try to take pictures only when we need them. We try to maximize our distance from the radiation source. We try to stay as far away as possible, but we're taking care of a patient, and we have to be right up next to that patient while we're performing these procedures, and that's where the radiation source is. And we have to shield ourselves, but as I talked about already, shielding ourselves with the current technology isn't necessarily great for our bodies. It can lead to overuse injuries over the lifetime of our career that can be just as disabling as some of the other complications of radiation exposure. one of the tools that we can do is come up with an alternate way of imaging and an alternate way of performing these procedures that perhaps doesn't rely on the use of radiation. While it's been helpful for us over the past several decades, it's time for something new. Next slide. I'm going to turn it over to Vikash Goel, who's going to talk about something he's been working on to help reduce our exposure to radiation and improve the imaging that we have in order to perform these procedures. Vikash?
Thank you, Dr. Eagleton, and thank you, Dr. Mon, as well, for speaking to these critical issues. So actually, for my first part, I'd like to circle back to where we started this session. Next slide, please. So, you know, I'm not a doctor. I'm an engineer. I'm a scientist. I'm a computer scientist. But Dr. Roy Greenberg, the third name on this screen, he brought me into medicine. He was one of the most talented, most prolific healers that I have ever met. And what's more, he was a prolific teacher, a really prolific innovator. And I consider him to be one of my mentors, and he was a very close colleague of Dr. Eagleton's as well. Dr. Greenberg brought me into his team of researchers at Cleveland Clinic, and therefore I had the privilege of coming from a blank slate outside the field of medicine and becoming deeply immersed in the Cleveland Clinic Heart and Vascular Institute. So this is, you know, one of the country's, one of the world's top heart and vascular institutes. And I ended up spending 10 years there. And for me, this was, you know, profoundly educational. And again, I'm not a doctor, so I'm going to speak from the outside experience. And, you know, it might sound funny, but I learned surgery is not like on TV. It was eye-opening. You know, we think of stents as a minimally invasive alternative to open surgery, minimally invasive. So the idea is doing a procedure with as little collateral damage as possible. And that's been achieved in many ways, but ironically, it's also created this whole new danger. And on the screen right now, we see, you know, 4 names of leaders, of people who really transform medicine, who we don't have around anymore, far before their times, potentially because of this radiation question. You know, Dr. Greenberg had always envisioned using computation to improve on these types of procedures, these endovascular procedures. And when he developed cancer, our team refocused very specifically on improving radiation safety, while also trying to improve the images, like Dr. Eagleton was talking about. And we continue to march on in his memory. Next slide, please. And so this is what we came up with. You know, Dr. Eagleton had shared the 3 prime ways that we practice ALARA in medicine: spend less time with radiation, stand further away from it, and wear shielding or use shielding. And these are all really good, extremely important, but they're kind of low tech. X-rays haven't fundamentally changed in decades, as Dr. Eagleton was describing. And so we wanted to bring modern technology into it, you know, find a way to use the same high-tech stuff that we see in video games, in movies, in TV, and use it for medicine. So this is what you see on the screen. This is what we developed at Cleveland Clinic. We make these vivid 3D maps of the arteries, like you see there on the screen, the arteries that the doctors need to navigate. And then we use a modern high-tech electromagnetic measurement technology to help them guide their tools through the body. So if you think about the difference between, you know, in the 80s and 90s when we were using these fold-out paper maps when we were on a road trip, and think about today's Apple Maps, Google Maps, Waze, that difference, you'll start to get the idea. Next slide, please. So hopefully by now you're starting to appreciate the true scale of the issue that we're here discussing. It's bigger than any of us, bigger than any one answer, but it is such a widespread concern. This is our little piece of innovation, our way to try to make things safer for the caregivers in our nation. You know, so it's like GPS for the human body. We created this technology at Cleveland Clinic and actually have FDA clearance for the first version of it that we're starting to use at key hospitals across the nation. And this is interesting because we do these really cool looking 3-dimensional visualizations. You can contrast that to the little example Dr. Eagleton gave of fluoroscopy, and you can appreciate that it's potentially a much better way to see. So when we talk to doctors as we're rolling this out, we hear a lot of appreciation for that, and at the same time we hear a lot of concern about the radiation. So we're talking about two different things that we're trying to do to improve things at the same time. And the pioneers that we've spoken of, they were groundbreaking physicians. But now we have huge numbers of doctors who are spending their whole careers doing these procedures. And cancer is probably the scariest concern, but as I mentioned, I'm a scientist. I also wanted to mention that, new research has found links between this radiation and other problems. We talked about cataracts, we talked about the problems that come from wearing those lead garments. And, I've said before, I feel like I'm an inch shorter every time I walk out of one of these operating rooms, having worn those lead garments for those hours. But some more recent studies, there was a study published in 2017. They found DNA damage in doctors' blood right after one of these endovascular procedures. There was another study that found cognitive deficits in doctors and nurses exposed in the cath lab. So cognitive deficits, so we're talking about language skills, stuff like that, but even short-term memory in surgeons. So you look at that, other studies find links to depression, chronic inflammation. These are all harms that we want to find better ways to avoid. And this technology, this is our piece of how we're going to try to avoid making these harms just something that we accept in our society. Next slide, please. I did also want to speak a little bit about how we see the work that we're doing, and other related innovations, other ways to address this problem of radiation. We also see them being really relevant to the needs of our troops and the needs for of our emergency first responders. And when we look at the types of injuries that are the most risky, close to the top of the list after trauma, like from a battlefield wound or from a car accident, is internal injuries, internal bleeding. So we're talking about the kind of bleeding that you can't use a tourniquet on. We know from research there are ways to stabilize patients like this with endovascular therapies like Dr. Eagleton practices. But there's no way you can get some of these patients into one of these X-ray rooms fast enough. We're talking about a technology, right? It's large. It uses a lot of power. It's not portable. There's a lot of shielding required. But technologies like what we developed at Cleveland Clinic, other innovations that are related, they could be an answer to this need. Just as meaningful for civilian emergencies and for military emergencies. If we can find ways to support doing these endovascular techniques without needing these X-ray systems, we can make a real difference here. So again, we see technologies like this as different pieces of a puzzle to solve a problem. This is the way of the future, right? So doctors, nurses, technicians, everyone who provides care doesn't have to get zapped with huge radiation doses to do so. So our troops can have the best shot at recovering from injuries. Fundamentally, we believe that today we're seeing a lot of avoidable harm, and we want to change that. Thank you.
Thank you so much. Very, very moving remarks from all of you. That was so helpful. So what we wanted to do is talk about solutions. What can you in government do to address these issues? Next slide, please. So first off, in 1994, the FDA issued a report warning patients and clinicians of these health dangers. And they specifically cited cancer, all linked to fluoroscopy. So 1994 was a long time ago. And we are seeing increased, as you heard from the doctors, increased health conditions leading to increased use of this procedure. And yet we have not heard more from FDA on this. So that's a real concern. The CDC has also issued warnings that redundant x-rays causing unnecessary risk to patients and doctors, right, should be avoided. That's the whole principle of ALARA that Dr. Eagleton talked about. And then finally, no government action to reduce radiation exposures from fluoroscopy or similar procedures has happened. So there's really this void in changing the standard of care. Thank goodness there are some innovations coming down the pike that are offering alternative procedures, or I should say alternative tools for the procedure, providing that same functionality, even better functionality, with no radiation exposure. So at least that is happening in private sector, but there's still these gaps from the government side that need to be addressed. So next slide, please. So what we'd love for you to take away today to think about are things that we can do to help patients and healthcare workers to avoid this unnecessary risk. So first, collecting data is key. We need to know the avoidable cumulative lifetime medical radiation exposure for healthcare professionals and require this reporting by hospital systems. We need new standard for healthcare workers on radiation exposure risks as part of a national data gathering system to inform patient safety strategies. We need private, public, military, and VA health systems, in other words, all health systems, to use new technologies that reduce or eliminate radiation exposure. It's unacceptable at this point in 2021 when we have alternative technologies to continue to put our patients and healthcare workers at risk. FDA should update that 1994 report. That is too old. It needs to be updated. We now have new information and can raise the standard of care based on that information. And then finally, CMS, Centers for Medicare and Medicaid, needs to adapt the MCIT rule, which is the Medicare Coverage for Innovative Technologies rule, so that these new technologies that have no radiation exposure, no risk, need to be not just approved by FDA, but then they have to be covered by CMS. And when they have this breakthrough designation, they should be covered right away. If FDA approved it, why can't it be available to patients right away? Currently, it can take up to 3 years to get a code, to get through that reimbursement system through CMS. And that's 3 years that people could be dying or struggling with avoidable health conditions. So those are a few of the recommendations that we have for you. And we'd love to close out with some questions. And you're welcome to post questions in the chat box. You can send them to me or post for all panelists. I think it's really important that folks understand the risks and that there are actual solutions. There's things that we can do about it. I'm seeing some questions come in about the different types of innovations that were described, and how available are these now to surgeons and healthcare systems, and what more needs to be done to make it as available as possible for patients and healthcare workers. Why don't we start with Dr. Eagleton for that question?
Yeah, so most of the newer technologies, such as the ones that Vikash Goel talked about, are not readily available across the United States yet. These are new technologies with new approvals that they're in the process of exposing vascular surgeons and vascular interventionalists to, but they haven't been widely adopted yet. And while Vikash works for a single company that helps to develop this type of technology, he's not the only one. There are multiple companies that are working on this type of technology in the country. And hopefully within the next 5 years, we'll see more implementation of it, but it's not readily used right now, and it should be.
Is the reason lack of awareness of the new technologies, or what do you think some of the barriers are?
That's one of the biggest ones, is just lack of awareness of the technology that's out there. And physicians are a stubborn group. We get stuck in our ways of doing things. And if we've been doing it that way for 30 years, to adopt a new technology isn't always so easy for us, believe it or not. And so, teaching us about it, showing us that we should use it, showing us that we should trust it, and that it should become the new gold standard is a huge step to take. You're changing the thought process of thousands of people across the country, and that's slow to happen.
Yeah, that's very helpful. Vikash, I'd love to hear your perspective on the inventor side of things. Are you seeing that being the main challenge as well, or are there other challenges to point out in adoption of this?
No, I think, like Dr. Eagleton said, we're a small company trying to do something with this, and just getting it off the ground, getting our technology, the awareness of our technology up, it is an overwhelming task for a small group of people, and so I really concur with that being one of the challenges. We are seeing the awareness of the risks increasing, but really. It's very recent that we've started to see it become a focal topic in medical conferences, and so I think that awareness, that education, is one of the biggest things that can be done to help.
I don't think it's just an education about the new technologies that are out there. I think there's a general awareness. There hasn't been a general concern until the past couple of years about radiation safety for ourselves. We've been worried about it a great deal for our patients and the single dose procedures that they get exposed to. But it's a cumulative effect that happens over our careers that we need to be a bit more focused on. And it's not just the physicians. I don't want to be the doctors are the only ones with this risk. It's everybody who's helping in these procedure rooms. So it's nurses, it's x-ray techs, it's the people that help us get all these procedures done. It's not just one person in there doing a procedure. There's a team that's in there, and that team is being exposed. When we looked at some of the studies that I tried to identify who during a specific fluoroscopic procedure was most exposed to the radiation, it actually wasn't the surgeon, probably because they set up the room to give themselves the most protection because they were the most aware of it, but it was actually the anesthesiologist or the nurse anesthetist who was at the patient's head, keeping them alive and keeping them safe during the procedure, that had the greatest exposure. And they probably didn't, until we did these studies, weren't even aware of it.
That's very, very interesting. Okay. We have a question about the cost of the new technology compared to the current technology. How does that compare just generally?
It's tough to compare since this is just becoming a commercially available device. The cost is more expensive than normal tools that we use, such as catheters and wires. The cost is less, though, than the expense of a fluoroscopic machine, which can be $1 to $2 million just to purchase one of those. So I think this is a smaller cost up front, is my understanding, but I'll let Vikash talk about that in a little bit more detail from a company standpoint.
Yeah, sure. I mean, this is actually something that comes up a lot when we're sharing our technology with hospitals. And, of course, there is this constraint that right now there is not a reimbursement code that the systems use can fall under. And so, then the hospital has to look at how they're going to evaluate the overall value. We're still in the early days of our nationwide launch, so we expect that we'll see more data that supports this idea. But what we're hoping to see is that just the fact that you can see better through some parts of what your procedure is, our hope is that will allow physicians to be simultaneously more efficient as well as more accurate in their procedure. And this is something that we're hoping to see with what we're doing. But if that is the case, if that means that we could potentially reduce the overall cost of the procedure, even if the device adds a cost at the beginning, just because it's so expensive to run these types of rooms and to keep all of those people working on a case.
Yeah, and you touched on this reimbursement code and the Medicare coverage for innovative technology issue. And I know the rule just closed on that April 23rd, or the comment period for that rule closed. Could you maybe explain a little bit more about why that is so critical, that once you have that FDA approval to get the CMS coverage, and how does not having that coverage block patient access or doctors using this?
Well, I mean, it's very simple at its surface. When in our country, when you provide medical care, typically it's reimbursed to some degree by a payer, whether that's Medicare or a private insurance company, and it's essential for a technology to be widespread in adoption, for there to be a means for that to be achieved by the hospitals. And until you have those codes, until you have that framework set up, what you're really asking is for the hospital to take a leap of faith that that is not as supported by the federal government as we'd like to see.
Okay, leap of faith. That's great. Okay, very helpful. And then, you know, as at the earlier part of this discussion, we talked about the increased health conditions and increased use of this procedure. Is that something that's going to continue? Like, what does the future look like as far as the need for this? I don't know if Dr. Mohan or others want to comment on that, but I would love to hear that response.
Certainly the interest in performing less and less invasive procedures to treat life-threatening conditions is going to continue to rise. Absolutely. You know, we've seen a huge shift. Well, I focused on aortic aneurysms. There are other areas that have blown up even faster than aortic aneurysms. They're doing percutaneous aortic valve replacements now. We're going to be doing percutaneous mitral valve replacements. There's mapping of the electrical physiologic pathways in the heart that allow us to go in with fine tools and ablate those pathways to fix rhythm problems that patients have with their hearts. All of these require fluoroscopy currently to perform. And those are areas that we can help to reduce the radiation exposure and help to come up with better ways of modeling and imaging those anatomic regions in order to perform these procedures more safely for the healthcare team. That's just cardiovascular ones. There are also orthopedic procedures that are done. There are neurovascular procedures that are done working on blood vessels in the brain. So the application of this type of technology and the application of technologies that look to reduce radiation exposure are drastically needed across all healthcare specialties.
Also, Liz, if I can make a comment, as you know, our life, how people are living longer. Once you get people into 80s and 90s and 100, there is no way we can do surgeries, heroic surgeries. So most of these folks need interventions of this kind. So non-invasive endoscopy and fluoroscopy is increasing, is rising like crazy.
Okay, interesting. People living longer too. Okay.
Yes.
And then as far as the technology, sort of the old and the new, how do they compare as far as visualization, I can't say that word, navigation, so that that would be helpful too, that functionality. How does that compare?
So I admit I've only been exposed to one company's technology, and not all the companies that have been involved in this. I've only been able to use one, but there are others out there. But the three-dimensional picture that's provided is tremendous. You know, most people, when we do the procedures now, we're given a two-dimensional grayscale image, and you have to be able to convert that in your mind to a three-dimensional picture in order to understand the type of procedure that you're doing. That ease of converting that two-dimensional picture into a three-dimensional picture is only easy for about 20% of the population. The other 80% struggle with this a great deal, and that becomes difficult with regard to training and with regard to performing the procedures and with regard to the accuracy of performing these procedures. One of the absolute benefits of this type of technology is that the picture it gives us is not grayscale, it's color. It gives us more of a realistic picture. And it allows us to have actually the three-dimensional picture so that we can understand where we actually are in the body and what our catheters and wires and stents are doing in that location in the body. And that's just something we have to, I don't want to say guess at, but use our experience to understand in a two-dimensional grayscale image. And this takes that away, and it's going to make the performance of these procedures safer and quicker.
Great. Okay. Another question. So you did touch on this a bit about how medical conferences are starting to talk about this. Just hearing all these statistics, it's so alarming. I'm surprised there's not more of a public outcry. So do you have comments on sort of the profession? And as you said, all healthcare workers, from doctors to technicians, et cetera, what's going on from that perspective?
It's a great question. I don't regularly attend the other allied health professionals meetings, so I don't know if this is on the agenda items for national nursing meetings or national radiology technicians meetings. But it certainly over the past 5 years has started to gather attention at the national vascular meetings and cardiovascular meetings. And really it's just our awareness of an ongoing problem has been slow for us to realize. You know, it's going to sound terrible, in many instances, physicians in some places are looked at as a disposable commodity. It doesn't matter if you get exposed, you have a short career and you're going to move on and we'll bring in a new crew. But we need to do better than that. And I think as physicians, as vascular surgeons, we certainly have recognized that. And then we have key leaders that have had healthcare problems, which really brings it to the surface. And so we spend a great deal of time now educating our trainees about how they have to practice radiation safety if they want to have a long, safe, and healthy career. Those of us that were in this in an earlier stage, with Ted Dietrich said it, felt invincible. You can't see the radiation exposure, you can't feel it. The effect of it is going to be later in life, and so you can kind of bury your head in the sand and be naive about it. And it's a time for us not to be naive about it anymore.
Yeah, bury your head in the sand. That's a great analogy. Dr. Mohan, did you have anything you wanted to add to that?
I personally watch some of these procedures, using the IOPS, Dr. Eagleton and Vikash Goel have mentioned, and they're incredible. What they have done to some very difficult patients into very difficult procedures. They were able to do it faster, safer, and with an incredible accuracy.
Okay. Faster is important. Why? Why is that important to have these procedures be faster?
We have a number of studies that have shown the shorter the duration of an operation, the better the patient's outcomes and the fewer adverse events that'll happen in the perioperative period. It's just safer. It gets them off of anesthesia quicker. It gets them back to the recovery room quicker. It's just time and time again, that is a factor that we know is improved with outcomes.
Okay. So that's across the board.
Yeah.
Okay.
And not just in
Great.
endovascular, minimally invasive procedures, even in our invasive procedure, every procedure, if you can do it in less time, the patient's going to do better.
Okay. What about, we are hearing more and more in medicine today, gender differences. Are you seeing any particular impact from MRI exposure on women who are healthcare workers?
I don't know anything about that area whatsoever. So MRI does not expose people to ionizing radiation. It's a completely different imaging modality.
Okay.
We don't use MRI technology to perform our procedures. I think there are very few limited procedures that rely on MRI directly. It's much more cumbersome tool to use. And for the most part, my understanding is predominantly used just for imaging. Again, that's a completely different topic than what we were focused on here. We're focused on using tools that generate ionizing radiation, such as fluoroscopy, such as computed tomography, but completely different topic altogether.
Thanks for clarifying that. That's important to understand different kinds of radiation. Okay.
I think there is an interesting relevant point to that, though. That when you look at all of the various medical and surgical specialties, certainly there are gender imbalances in many of them, but the ones that have the fewest women joining when they complete their training tend to be interventional radiology and vascular surgery, the ones in which there is a lot of radiation exposure involved in practice. I personally know of some women surgeons that chose to stop at a certain point early in their careers in order to protect their reproductive health, and it is a concern, and it is affecting the overall balance in the field. So this is something that certainly warrants, I think, more investigation and research.
Okay, interesting. All right, we're closing out. Maybe a final thought on the role of government in trying to address this. Do you have any thoughts or insights on that?
No, we could just use help across the board in every aspect of this, obviously. I think that the biggest area I'd like to see initially is on data gathering and reporting on radiation exposures amongst healthcare providers. And better understanding what's happening across the nation with regard to that, so we can better understand the problem and then understand who's being adversely affected by it in a more scientific fashion.
Yeah. Okay. All right. Well, I think that I'm not seeing more questions, so I think that we will start to wrap things up. Do you all have any final thoughts you'd love to share with folks today?
I just thank you all for your time and letting us talk about this important issue. This isn't going to go away, and we need to come up with better ways to address our procedural imaging and our exposure to a lifetime of radiation.
Okay, Vikash, any final thoughts?
Yeah, I'll echo Dr. Eagleton's. Thank you very much for giving us the chance to speak about this. You know, I'll just leave you with the thought that I feel confident that if we take the same modern technology elsewhere and really foster the innovation around it, really help you know, understand the need for it, that we can get to a point where we look back at how it is today and you know, feel very thankful that we don't do things that way anymore.
Yeah, a brighter future. Dr. Mohan, any final thoughts?
Yeah, this is a very innovative technology, and it deserves what Dr. Matt Eagleton and Vikash are talking about. It should be strongly encouraged and pushed through the legislative process.
Okay, great. Well, thank you so much for sharing your expertise today. All those who have participated, we will make sure you have a copy of the slides, access to this video link, and we are here to be a resource for you if you have any questions, and we look forward to working with you to make a difference for patients, doctors, and all healthcare workers. Thank you so much.
Thank you.
Thank you.